Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very interesting session. Today, as you can see the thumbnail, we are going to discuss in details about the approach to thrombophilia. Now, this lecture will be divided into two parts, okay? So, it will be taken as part 1 and it will be taken as part 2. Now, in the part 1 of this lecture, we are mainly going to discuss about what is thrombophilia and what are the different kinds of thrombophilia. We will discuss in details inherited thrombophilias as well as acquired thrombophilia. Now, a lot of questions comes in the exam, in the final exam, okay, and they are very commonly asked questions. For example, directly a 10-mark question on factor 5 laden mutation can come, or direct questions on APLA syndrome and HIT syndrome can come, okay. Now, in the second part of the lecture, or in the part 2 of this particular session, we are going to discuss in details about the laboratory diagnosis of thrombophilias, wherein we are going to see the introduction, general principles, indications, limitations, and the different tests which are performed, okay, in the lab diagnosis of thrombophilias. Not only that, in the part 2, we will also discuss about the laboratory diagnosis of deep vein thrombosis and pulmonary embolism in short. Now, a very quick disclaimer. Now, before you start this particular video, it will be very helpful for you if you revise thrombosis session, which has been covered in the general pathology section. Okay, if you can, see this particular video on thrombosis, which is covered in general pathology under hemodynamic disorder. Also, if you cover hemostasis, okay, the basic mechanisms of hemostasis again covered under the hemodynamic disorders under the general pathology section, as well as under the hematology section, as we have discussed in details about the platelet versus the coagulation disorder under the bleeding disorder section, okay, under the bleeding disorder section. If you can see this particular videos and then watch this particular video, it is going to make a lot of sense. So let us begin today's topic of discussion without wasting any more time. So first of all, we have to understand that we are reading or dealing with thrombophilia, also known as hypercoagulability, which is one of the components of Virtue triad. So what are the components of Virtue triad? Yes, what is it? So we are basically having endothelial dysfunction, altered blood flow, and thirdly hypercoagulability, also called as thrombophilia. Now, what is thrombophilia? It is a hemostatic disorder in which there is a predisposition to thrombosis which occurs due to either inherited disorder or due to acquired disorder. So, under the inherited disorders or inherited thrombophilias, we have activated protein C resistance, okay, and the most common cause of activated protein C resistance is factor 5 laden mutation. But remember, it is not the only cause and it cannot be used synonymously with activated protein C resistance. So there are many causes of activated protein C resistance, but the most common cause of activated protein C resistance is factor 5 laden mutation, okay, that is the most common cause, okay. The second important inherited disorder that we will discuss is the prothrombin G2021OA gene mutation. Then we will see about the protein C protein S deficiency, antithrombin deficiency, and also about homocystinemia, okay. So these are all the inherited thrombophilias. Among the acquired thrombophilias, we have autoimmune disorders like APLA syndrome, that is antiphospholipid antibody syndrome, which is a very commonly asked question in the exam. So very important question which can be asked, okay, from the acquired thrombophilias, okay. Then there are hematological disorders also which are causing acquired thrombophilia. So the most important ones are myeloproliferative neoplasms, which includes polycythemia vera, essential thrombocythemia, APML, okay. Paraproteinemias as well, PNH, TTP, HIT syndrome, sickle cell disease. Now, HIT syndrome is again very important question, okay, which is asked, okay, among the acquired thrombophilias. It can come as a separate long answer question. Then other acquired disorders include obesity, and there are other important factors like trauma, sepsis, surgery, malignancy, chronic inflammation, use of oral contraceptive pills or HRT, hormonal replacement therapy, hyperhomocystinemia, aging, prolonged immobilization out of any cause, for example because of prolonged bed rest for more than 3 days, or non-ambulatory states, or prolonged air travel. So prolonged immobilization can also predispose to acquired hypercoagulability leading to thrombosis, okay. So these are the basic classification of thrombophilia. We have seen the inherited disorders and we have seen the acquired disorders, and I have also said the most important questions which can be asked, as a separate long answer is the APLA syndrome, HIT syndrome, and among the inherited disorder, factor V laden mutation can be asked as a separate exam question. Okay, so let us begin. Now, what is Virchow stride? We have already discussed. So Virchow stride has been discussed in details under the heading of thrombosis. Okay. So basically, what is very important, that there are three important factors in the Virchow stride. One is the alteration in the blood flow leading to stasis, as well as the hypercoagulability, that is the thrombophilia. Okay, both these factors, they are basically predisposing to which type of thrombus? Venous thrombus. Okay, whereas the endothelial dysfunction or damage is basically predisposing to arterial thrombi. Okay, it is predisposing to arterial thrombi. Now, if you come under the arterial thrombosis and venous thrombosis, so let us just discuss in details, factors regarding the arterial thrombosis. Remember, vascular injury and platelet deposition, they are mainly involved in the pathogenesis of arterial thrombus. As I already said, that endothelial dysfunction or damage basically predisposes to arterial thrombi. Most cases of arterial thrombosis are not inherited, but they are rather acquired and include diabetes and hyperlipidemia. The inherited causes of arterial thrombosis, they are quite rare and they include homocystinemia and few cases of protein C and protein S deficiency. Okay, whereas in case of venous thrombosis, remember, hypercoagulability of the blood and stasis of the blood flow plays a major role in venous thrombosis, and the risk factor includes both acquired as well as inherited factors which are discussed above. Okay, so as I have already discussed over here, if you see that alteration in the blood flow, that is stasis, and hypercoagulability, both of them, they mainly predispose to venous thrombosis. Okay. Now, in contrast to arterial thrombosis, the causes of venous thrombosis are numerous and many cases are inherited. Okay, they are inherited. Now, first we are going to discuss the inherited thrombotic disorders in detail. Now, as I told you, the inherited thrombotic disorders itself can come as a long answer question, or they might just ask about the factor V laden mutation or APC, or that is antithrombin protein C deficiency, they can ask in details. Okay. So inherited thrombotic disorders, if you see, they are usually presenting with venous thromboembolism, and they are often transmitted in an autosomal dominant manner. Okay, they are often transmitted in an autosomal dominant manner. So remember, among the inherited thrombotic disorders, three important inherited thrombotic disorders are more common. Which are those? Activated protein C resistance. Okay. Which is basically caused by factor V laden mutation in majority of cases, prothrombin gene mutation, and number 3, hyperhomocystinemia. All these three, they are the more common ones. They are the more common inherited disorders or inherited thrombophilias. Okay, so these are evaluated first if any inherited disorder is suspected. If no abnormality is detected after extensively testing for these three main disorders, okay, then testing for antithrombin, protein C and protein S is carried out. Now remember, among Indians or especially among Asians, protein C deficiency is very much more common as compared to these three. Okay, so remember, if the question is the most common inherited thrombophilia among Asians, then remember the answer will be protein C deficiency. If nothing is mentioned, in that case activated protein C resistance is most common thrombophilia, inherited thrombophilia. Okay. Now, a major indication for testing for inherited thrombophilia is to screen family members. So, when you are suspecting that this disorder is running in the family and you want to screen them, screen the family members, so that is one of the major indication for testing for the inherited thrombophilias. The prevalence of inherited thrombotic disorder is higher as compared to inherited bleeding disorder. So, if you compare the thrombotic disorder, okay, with the bleeding disorder, remember, the prevalence of inherited thrombotic disorder is higher than the inherited bleeding disorder. Remember, we have already discussed in details about the bleeding disorders. Okay, Now, first we are going to discuss the most important thing. We are going to discuss the activated protein C resistance, and the most important cause of activated protein C resistance is factor V laden mutation. Remember one thing, okay, it is the most important cause, but not all cases of activated protein C resistance is due to factor V laden mutation. Remember this thing. So the most important thing, this factor V laden mutation. So this word Leiden is actually a name of place in Netherlands, okay. So because it was discovered in that place, so the name. So remember, this activated protein C resistance, it is the most common inherited cause of thrombophilia. Normally, factor V is activated by thrombin and it is inactivated by protein C and protein S. Now, this particular mutation, it is inherited in an autosomal dominant manner. It is now what is the frequency in the general population? It is 2 to 10%. What is the prevalence in thrombosis? Around 20 to 25% of the cases, okay, of inherited thrombophilias, okay, which are basically having thrombosis, they can be attributed to factor V laden mutation. Now, this basically predisposes to venous thromboembolism. So, what is the basic pathogenesis behind this mutation? So, the mutation in the factor V encoding gene leads to replacement of arginine by glutamine at position 506. So, this causes activated form of factor V resistant to degradation by activated protein C. So, as I told you, the factor V is inactivated by the protein C. So, because of this mutation, this particular factor V, the mutated factor V, it resists degradation by this particular protein C, and therefore as a result, what is happening, that the clotting factor is getting activated and clotting continues, therefore predisposing to thrombosis, okay. Now, this APC resistance that we are talking about, that is the activated protein C resistance, by whom? By the factor V, okay. Remember, 95% of the cases of APC resistance occurs due to factor V laden mutation. There are other causes of this APC resistance, which are pregnancy or use of oral contraceptive pills, malignancy. Other factor V mutations can also predispose to APC resistance, but majority of the case, 95% of the case, is because of factor V laden mutation. Therefore, the term APC resistance and factor V laden mutations, they are not synonymous. I hope you have understood this concept very clearly. Now, remember, this factor V laden mutation is common in Caucasians but rare in Africans and Asians. Individuals who are heterozygous for this disorder, they have 4 to 8 times increased risk of venous thromboembolism than individuals homozygous for this disorder. They have 80 times increased risk of venous thromboembolism. Now, if you look at the laboratory testing, there are two important tests which is performed for the detection of this particular resistance. So, one is your activated protein C resistance assay. If this ratio is less than 2, okay, then only you should go for a further confirmatory test, that is the genetic or the molecular testing, okay. It is done to differentiate whether the particular disorder, that is the APC resistance, whether it is hetero or it is homozygous, okay, because if you see, the clinical risk is different among the hetero and homozygous individuals, okay. So, this is the laboratory testing. So, the first important testing is the functional activated protein C assay. So, let me just repeat the pathogenesis once. Remember, thrombin activates the protein C, and this activated protein C in presence of the cofactor protein S, they will inhibit the factor number 5 and factor number 8, and this factor, when it is inhibited, it is going to inhibit thrombin as well, so clotting will be stopped, okay. Now, suppose if this factor number 5, they resist degradation by this activated protein C. If this factor 5 is resisting the degradation by the activated protein C, then what is going to happen? Then this inhibition of thrombin will not be there. So, the clotting factor pathways, they will be activated, and as a result, there will be more clotting and increased risk of venous thromboembolism, okay. So, APC resistance is present when addition of APC to test plasma does not result in prolongation of APTT or similar test. So, what is the basic rationale behind this particular testing? So, the basic rationale is that, so whenever APC resistance is there, so whenever you are adding this activated protein C to the test plasmas, even after addition of the APCs, the clotting does not occur, and whatever tissue thromboplastin time or the APTT, partial thromboplastin time, that is there, it is prolonged, okay. So, it is not prolonged, it does not result in prolongation of APTT or similar test. That means this particular activated protein C that we are adding to the patient's plasma, it is not able to inhibit the factor 5. Why? Because there is some kind of resistance. So prolongation of APTT or similar test after addition of activated protein C to the patient's test plasma is indicative of APC resistance. Okay, so there are two important assays over here. One is the first generation APC resistance assay, and there is the second generation APC resistance assay. So let us see. So how do we carry out this particular test? So in the first test tube, you are placing the test plasma and you are adding the APTT reagent along with the calcium. Now this is going to initiate the clotting process, and the time taken to the clotting is calculated. Okay, and in the second tube you are again giving the test plasma, and in addition to whatever you have given in the first tube, you are also adding the activated protein C, and after this you are going to calculate the clotting times over here, and then the ratio of the clotting time in the second tube, that is without the with the activated protein C, and the clotting time in the first tube, okay, that is without the activated protein C, okay, it is compared. So the ratio of the clotting time in the second tube to the ratio of the clotting time in the first tube is basically compared over here. Okay, so normal individuals, if you see normal individuals, the ratio is 2 or more, as the activated protein C will be able to inhibit the factor number 5, and therefore the clotting process will be slowed down, and as a result the clotting time will be delayed. So the ratio will become more. Okay, whereas in conditions of APC resistance the ratio will be less than 2. Okay, so basically just once more I am telling you, so whenever you are adding activated protein C, remember one stuff. Okay, whenever you are adding the activated protein C, okay, as a result, if the patient plasma if the patient plasma is normal, okay, and the factor number 5 is normal, then that will be inhibited by the activated protein C. So in the second test tube, when you carry out this APTT testing, in that case you will see that the clotting time is prolonged. Why? Because the activated protein C has inhibited the clotting process, right? Whereas if you see if the patient's plasma is containing the factor number 5, which is basically resistant to the degradation by the APC, then in that situation what is going to happen? In that situation the clotting time will not be prolonged, and therefore the ratio will become less. So normal individuals may, what will happen? The ratio will be more, it is 2 or more, whereas in conditions of APC resistance the ratio will be less than 2. Okay, I hope you have understood this very clearly. Now comes the second generation APC resistance assay. Now everything is same, okay, as the first generation. Just over here what we are doing, that the procedure is similar to the previous one, except that the test is first mixed with factor number 5 depleted plasma. So the test sample, that is the patient's plasma, is mixed with factor 5 depleted plasma. And why it is done? To reduce certain analytical variables which can cause some kind of interference with the interpretation of the result. So by doing this, the assay becomes highly sensitive and specific for factor 5 lead-in mutation detection. Okay, so this particular testing that we have seen, that is the first and the second generation APC resistance assay, that is for factor number 5 lead-in mutation detection. Okay, the testing is indicated mainly in young person with unprovoked deep vein thrombosis or pulmonary thromboembolism. Okay, so once this particular test comes out to be positive, you have to carry out the molecular testing so as to confirm the diagnosis, and not only confirmation but also to understand whether the individual is homozygous or heterozygous for the particular mutation that the person has inherited. So for the molecular testing, a restriction enzyme MNL is used to digest the 267 base pair amplified fragment of the patient's DNA. Normally via this restriction enzyme based digestion of the patient's DNA, we are getting normally 3 fragments. If there are more or less or number of fragments, then that means that some abnormality is there. Okay. So this was the first particular condition that we have discussed, that is the inherited thrombophilias, and we have discussed the most important type of inherited thrombophilia, that is factor number 5 lead-in mutation, okay, that is leading to the activated protein C resistance. Okay. Now the second important inherited thrombophilia, if we see, is basically your prothrombin gene G2210A mutation. Okay. So first of all, this particular inherited thrombophilia is common in Caucasians and they are uncommon in Africans and Asians. So over here, what is the pathogenesis? There is a guanine to adenine substitution in the promoter region of the prothrombin gene. Again, it is an autosomal dominant disorder. It is what is the frequency in the general population? 2 to 4%. And what is the prevalence in thrombosis is 5 to 10%. And it basically increases the risk of venous thromboembolism. Heterozygotes, they have twofold increased risk of venous thromboembolism. Although the mutations leads to high levels of prothrombin in the blood, these levels often falls within the reference range of most laboratories. Therefore, just carrying out the basic clot-based assays initially does not help. Therefore, molecular testing is required for making a diagnosis of this particular inherited thrombophilia. This mutation, remember, it has not been detected in the Indians. Now, deficiency of the protein C or protein S and of antithrombin. Let us see. The third important variety of the inherited thrombophilias, all these different types. So remember, two vitamin K dependent protein, that is protein C and protein S, in combination they are inhibiting the activated form of factor number 5 and factor number 8, as we have already seen over here. If you see, I have just shown you over here that activated form of protein C along with the cofactor protein S, they are inhibiting the factor number 5 and 8, and therefore they are inhibiting the clotting process. Okay, so basically over here, the protein C and S, they are analyzed by clot based assays. Now remember, for any factor evaluation, we are having two types of assays. One is clot based assays, one is chromogen based assays, and we have discussed in details about this clot based and your chromogenic based assays in details in the lecture of lab evaluation or lab diagnosis of thrombophilia. So in the next part, in the part 2, we have discussed over there. So I am not discussing again over here. Okay. So the protein C and S, they are basically analyzed by the clot based assays. Remember, protein C and S, they are low in conditions of acute thrombosis, liver disease, vitamin K deficiency, DIC, newborns, and in case of oral anticoagulant therapy, for example with warfarin. Protein S is also reduced in pregnancy. Now remember, one of the very important clinical presentations of this deficiency is purpura fulminans. What it is, I will discuss in details in the next lecture, that is in the part 2, when we will discuss the laboratory diagnosis. So under the heading of clinical features, I am going to show you what purpura fulminans is. Now this particular protein C and S deficiency leads to increase 4 to 5 times increased risk of venous thromboembolism. Now, the next important deficiency is that of antithrombin. Now, antithrombin neutralizes multiple clotting factors including thrombin, factor number 9, factor number 10, as well as factor number 11 and 12. So, antithrombin measure is basically measured by chromogenic assays. Okay, remember, protein C and S by clot based assays, and as I told you, antithrombin measured by chromogenic assay. It is again low in conditions of acute thrombosis, liver disease, again heparin therapy, nephrotic syndrome, pregnancy, and also under conditions of inflammation. Okay, it is basically low. And remember, individuals with this inherited deficiencies are lethal in utero, and there is a 10 times increased risk of venous thromboembolism. Now, as we have seen in many conditions, the protein C and S, they are low in many acquired conditions. Therefore, before you evaluate this particular condition or interpret the laboratory result, remember, it is necessary to be aware of these pre-analytical variables before interpretation of the lab values, because you have to see whether the patient is having any such condition or no. So that is why, remember, such testing is avoided under conditions of acute thrombosis. Okay, so if you compare all these three disorders, all these three, they are autosomal dominant in nature. If you look at the prevalence and thrombosis for protein S, it is 3%, leading to increased risk of venous thrombosis, 2 to 6% for protein C deficiency, leading to venous as well as arterial thrombosis, and for antithrombin deficiency, it is 1%, leading to venous thrombosis. If you look at the frequency in general population, it is 0.7 to 2.3 for protein S deficiency, 0.2 to 0.4 for protein C deficiency, and 0.02% for antithrombin deficiency. Now remember, both the protein C and protein S deficiency, they are most commonly seen among the Asian population, and even among the Indians, these are more common. And they basically present with thrombosis, and the thrombosis over here is spontaneous and begins in early life. Any inherited condition, they begins in early life. Okay. Unlike the point mutation, which is causing factor 5 laden mutation, or the prothrombin mutation, unlike the other two inherited thrombophilias, remember, there are numerous mutations which can cause deficiencies of protein C, protein S as well as antithrombin. Therefore, molecular diagnosis, it is not at all helpful for the diagnosis of protein S, C and antithrombin 3 deficiency. The diagnosis is basically carried out by functional and antigenic assays only, that is the clot based assays and the chromogenic assays that I have already said. Okay. Next important condition of inherited this thing, that is hyperhomocystinemia. Remember, it is autosomal recessive in nature. There is an increased levels of homocysteine associated with increased risk of both arterial as well as venous thrombosis. Now over here, although we are discussing under the heading of inherited thrombophilias, but hyperhomocystinemia can either be genetic, inherited, or it can be acquired. So what are the genetic cause? Because of cystathionine or beta synthetase deficiency. So there is a cystathionine beta synthetase deficiency can lead to this hyperhomocystinemia, and there are certain acquired causes of hyperhomocystinemia like vitamin deficiencies, for example deficiency of folate, B6 and B12. Remember, the quantification of homocysteine is done by HPLC or fluorescence based immunoassays. Now what is the prevalence and thrombosis of this disorder? It is 20 to 30%. So there is a very high prevalence among the different causes of thrombosis. Okay. Now elevated clotting factor levels. Now higher factor number 8 levels have been found to be associated with increased risk of thrombosis. Okay. So high factor number 8 levels are associated with increased risk of thrombosis. And how do you evaluate the factor number 8? Again, there are clot based assays and there are chromogenic assays, which we will discuss in details in the next lecture, that is in the part 2. Now since factor number 8 is an acute phase reactant, estimation of the CRP level should be carried out to exclude inflammation, okay, before interpretation of factor 8 levels. Okay, remember, increased levels of factor 9 and 11, they are also associated with increased risk of thrombosis. So you have to evaluate the levels of these clotting factors also, okay, while evaluating the inherited thrombophilia. So we have discussed in details about the inherited thrombophilia. First, we have started off with the APC resistance, that is activated protein C resistance we have seen, which is mainly caused by the factor 5 laden mutation. Then we have discussed in details about the prothrombin gene mutation. Then we have seen about the protein CS and antithrombin deficiency. After that, we have read in details about the hyperhomocystinemia and then elevated clotting factor levels. Okay. So with this, we have discussed in details about the inherited thrombophilias, which again itself is a long answer question and you have to write all these points in details in the exam. Now we are going to discuss about the acquired thrombophilia. So among the acquired thrombophilia, there are many causes, but we will discuss the most important ones. So OCP use and pregnancy, how they are increasing the risk of thrombophilia. There is an increased thrombosis risk which occurs due to an increased synthesis of clotting factors in liver and decreased synthesis of antithrombin. APLA syndrome we have already discussed in details under the section of thrombosis. Remember, APLA syndrome itself is asked as a full long answer question in the exam. So among why we are discussing the APLA syndrome, because it is one of the important acquired thrombophilia conditions, and over here in the lab diagnosis we are basically detecting the presence of anti-phospholipid antibodies. The three most important ones are there. One is the lupus anticoagulant, anti-cardiolipin antibody and anti-beta 2 glycoprotein 1 antibody. Although and then just remember one very important concept over here, and we will also I will also repeat this point very importantly when we discuss about the laboratory diagnosis. What is the important point? Remember, although anti-phospholipid antibody they cause thrombosis in vivo, these antibodies they inhibit the coagulation in vitro. So try to understand this condition. We are reading about the thrombophilias, right? So anti-phospholipid antibodies inside the body of the individual, okay, for example, there is a mother who is suffering from the APLA syndrome. So inside that mother's body you will see that anti-phospholipid antibodies, they are promoting or causing thrombophilia or thrombosis inside the body. But the same antibody, okay, outside, when we are testing for the particular antibody, they are acting in an opposite manner. In vitro, under the laboratory conditions, they are inhibiting coagulation and they are increasing the clotting times, especially the APTT time. Okay. So this is a very important concept to understand. Therefore, remember over here under the heading of the APLA syndrome, basically there is a concept of how to evaluate the lupus anticoagulant. Although I have discussed in details about all these three tests, okay, under the heading of Apla syndrome, which has already been discussed under the section of thrombosis. But over here I am going to discuss in details about the lab diagnosis of the lupus anticoagulant. So detection of lupus anticoagulant, there are two important assays over here. One is the tissue thromboplastin time inhibition test and another one is the dilute Russell Viper venom test. Now remember, if you can remember this test, if you can understand this test, if you are able to, if you are able to remember everything about this test, it is all right. But if you are not able, no problem at all. Okay, I will tell you a shortcut as well. But you have to remember these two names, that is the tissue thromboplastin time inhibition test and the dilute Russell Viper venoms test. Both these tests are basically used for detection of the lupus anticoagulant. So first we are going to see the tissue thromboplastin time inhibition test. Over here, basically remember the prothrombin time using dilute thromboplastin reagent is compared with the prothrombin time using thromboplastin reagent of standard concentration. So we are basically comparing the prothrombin time. First we are making use of dilute thromboplastin reagent and later we are performing the same test using a thromboplastin reagent of a standard concentration. Okay. So with the dilute reagent, the prothrombin time is more prolonged if the plasma contains lupus anticoagulant as compared to the normal plasma. The ratio of the prothrombin time of diluted reagent and the prothrombin time of undiluted reagent is compared with the normal control. The test is positive if the ratio is more than 1:3. Okay, with the help of example, if this is the normal person, so we are basically comparing first, for example, for a normal person, first we are calculating the prothrombin time using a diluted thromboplastin reagent. So if the thromboplastin reagent is dilute, so basically the time required for clotting will be more. So normally, for example, it is 13 to 14 seconds. So for example, we have got 20, and with the standard concentration of thromboplastin reagent, we are getting 15. So this is the basic ratio in the normal individuals. In individuals of the patient who are suffering from the disease, that they are having a basic, they are suffering from Apla syndrome. So basically, as I told you, outside in the laboratory condition, when lupus anticoagulant is present, it is going to delay the clotting time. Okay. So over here, for example, it is 30 seconds with the diluted reagent and it is 20 seconds with the normal concentration of the with the normal concentration of the thromboplastin reagent. So over here, for example, it is 20. So in compared with the normal, this is increase, in compared with the normal, this is increase. So if you look at the ratio of these two, if you divide them and if you see, it is coming to 9:8, which is actually 1 point something, which is more than 1/3. Yes. So this is what I have just shown you with an example. You need not, remember this for your exam purpose. Even if you just remember these points, it is more than enough. Similarly, we are having the dilute Russell Viper venom test. So over here in this test, they directly activate the factor number 10. Now this, how do we carry out? We are using dilute Russell Viper venom. It is diluted and it is added to the patient's plasma. Then we are adding calcium chloride as well as phospholipid, and then we note the clotting time. In presence of lupus anticoagulant, the DRVT is higher than that of the control. Normal ratio of the patient's clotting time to that of the control, if you see, it is less than 1:2. Normally it is less than 1:2. LA, remember, lupus anticoagulant, if present, partially neutralizes the reagent phospholipid. Therefore, they are causing prolongation of clotting time. Remember, as I told you, lupus anticoagulant is one of the anti-phospholipid antibody, right? So basically, if they are present in the patient's plasma, so they are basically inhibiting the phospholipid. And once they are inhibiting the phospholipid, they are going to prolong the clotting time. Now you must be thinking that, sir, how this is happening? Now we have already discussed this concept when we have read about hemostasis. Remember, basically when this clotting process is taking place, in one of the platelets, on the surface of the platelet, there are phospholipids. And it is on these phospholipid backbone that this clotting process is taking place, which is promoting the process of clotting. So the presence of phospholipid is very essential to this clotting process. Okay, if lupus anticoagulant is there, they are going to neutralize and they are going to bind with the phospholipid present on the surface of platelet, and therefore they are not going to allow this clotting process to occur, therefore causing a prolongation of the clotting time. The process is repeated with reagent with higher phospholipid concentration. Now, once this is prolonged, how to confirm? You just repeat with a reagent and you just give excess amount of phospholipid. Okay, so if after giving the phospholipid, the clotting times which were initially prolonged, if those clotting times are corrected, then that is confirmatory of lupus anticoagulant presence and therefore confirmatory of APLA diagnosis. The final report is given as a ratio of two clotting times, one which is measured at higher concentration and one which is present at a lower concentration. Okay, higher and lower concentration of the Russell Viper, this we are saying, okay, of DRVVT. If you have not understood this, it is all right. Just remember the names, and in that situation in the exam, just you give this particular flow chart. Okay. So if you do not remember the process, it is no problem, but you have to remember this particular flow chart for the diagnosis of lupus anticoagulant in the exam. So first you have to measure these APTT and DRVVT times. If both of them are prolonged, or if even any one of them is prolonged, you are going to do the mixing study. So mixing study means you are basically mixing the patient's plasma with the normal plasma. Okay. So if after mixing with the normal plasma, if the clotting time is corrected, okay, if the clotting time is basically corrected, then you evaluate for either factor deficiency or inhibitor deficiency. Because if if you add the patient's plasma and if the clotting time is getting corrected, that means the patient plasma is containing the factors, okay, maybe any factor. So that is basically indicative of either factor deficiency or any inhibitor is there which is inhibiting a particular factor. Okay, so further what will happen, that further what you can do, you can repeat the APTT after 2 hours. Okay, if the APTT is yet normal after 2 hours, it is indicative of any factor deficiency. But if the APTT becomes prolonged after 2 hours, that means there are certain factors or inhibitors present in the patient's plasma, which is again, which is again prolonging the APTT time after 2 hours. So this is indicative of presence of factor inhibitors. Okay, I hope you have understood. But for example, after mixing the patient's plasma with a normal plasma, if for example the clotting time is not corrected, then you perform confirmatory test for lupus anticoagulant. Okay, so basically if it is not corrected, that means it is indicated that lupus anticoagulant is present. But how do you confirm? You give excess amount of phospholipid. If after administration of excess amount of phospholipid, okay, the clotting time becomes corrected, then lupus anticoagulant is positive, and you should repeat the test after 12 weeks or more for confirmation of diagnosis. If there is no correction, then lupus anticoagulant is absent. Okay, so this is the first step. Now in the first step only, if both APTT and DRVVT they are both normal, then no lupus anticoagulant is present. So this is the very important flowchart with regards to the diagnosis of lupus anticoagulant. Okay, I hope you have understood this point in detail. Now, heparin-induced thrombocytopenia I have not discussed over here because I have discussed in details. Again, it is discussed under the section of thrombosis. Okay, I have already discussed over there, so kindly go and see that particular video for the same. Now, other acquired conditions like malignancies which are leading to thrombophilias. So, among malignancies, hypercoagulability is more common in mucin secreting adenocarcinoma, APML, myeloproliferative neoplasms and brain tumor. Now, hyperhomocystinemia, as I told you, they are both acquired as well as they can be inherited. So we have discussed over there and here also. It is a known risk factor for atherosclerosis, and acquired causes of hyperhomocystinemia includes vitamin B6, B12 and folate deficiency. So with this, we have discussed in details about the inherited thrombophilia. We have discussed in details about the acquired thrombophilia, and we have discussed certain very important tests like the testing for the factor V laden mutation and evaluation of lupus anticoagulant in the laboratory. Okay, now in the next topic or in the next session, we are going to start with the lab diagnosis of thrombophilia, and as you know, this is a very important long answer question which is asked in the exam. Okay, so thank you very much for watching this particular video.